I've never understood why, the other thing I want to do is show you some dental techniques that I think you can use. I've never understood why medical people are afraid to go in the mouth. I've seen ER docs with a laceration on the lip injecting in the wound to get it numb. And with one little drop of lidocaine by the mental foramen, the whole lip and chin gets numb, and then you can inject anywhere you want. They won't feel anything. So I'm going to show you a little bit of that too. Well, let's get started. You said the little one was forward?
Yeah, the bottom one.
The bottom. We went to Uganda, and this little Christian school had 400 students. The first step was to screen them all, and the interesting thing to me was that 95% of the kids had no dental problems. There is no junk food in this little village. In Puerto Rico, when I worked there, there's a little candy shack out in front of every school you drive by. And the kids, during their breaks or at the end of school day, about 2:30, they go out and buy sticky, sugary candies. And so decay is rampant in Puerto Rico. But here, 5% of the kids needed to have something done. And our setup was, this happened to be an adult, our setup was, am I in your way? Our setup was, let me get over here. Our setup was that we didn't have dental chairs, so we had the patient sit on the floor, in this case a metal pan, and the head is put on the left knee, if that's if you're right-handed. If you're working right-handed, if you're working left-handed, of course, the other way. But we were both right-handed, and this is Dr. Borland treating this lady. You can see the lamp is a flashlight here, and this gives you access. You can see well, and she also had a portable unit. Here's the suction in the handpiece. This is folded up like a suitcase, and you can check it as a bag on the plane. Here she is injecting anesthetic to do she did the restorative procedures, and I did the surgical procedures. This little guy asked her if he could have those glasses when the section was done, and so she had a ceremony where she presented them to him. And here you see again the headrest is this leg. He's sitting on a little, a small can that made him just high enough so we can see. And that's how we work in very rural areas. Sometimes we don't have enough light. We have to take them over to the window, and I had a roof that was being a little stubborn, so I needed a little bit more light, and so we did it that way. But the people, it's just amazing, 30 years after Idi Amin, these people have bounced right back. They're happy, and I was impressed with the country. That was in November. Here's a little different setting. This is in San Bernardino, and the group is a Buddhist group called Tzu Chi. You pronounce it fast, it sounds like sushi. And you can see they're very well equipped. And I think what I want to impress upon you here is that dentistry is difficult because it requires so much junk. If you're just going to do extractions, you still have to take anesthetic, syringes, forceps, elevators, sutures, 15 blades, and so it's just difficult to do. They even had some vans equipped here with 4 chairs each. They had 2 vans. But this group is they're very Chinese and very organized, and I'll tell you, it was a pleasure to work with them. They had everything labeled, everything in boxes. You can see all the stuff that this took. It takes hours to set up, it takes hours to tear down. And they had rows and rows of elevators. They had any kind of forceps you want. It was a pleasure to work with them. And This is just to show you, you can see this long table of instruments. There's just a lot of stuff you need. It's not like taking a stethoscope and a sig and a prescription pad and walking in and checking people and giving them the medicines. It's actually having to sit down and do a procedure on them. So I don't know what to tell you about you taking some of these dental emergencies. I'll give you my recommendation later, but all this stuff is just, that's why we couldn't take this much stuff to Uganda. You can't take 10 suitcases. And they have these fold-up chairs that fit into a bag, and they just, wherever they go, they have stuff to set up. This lady was very happy. She had a difficult procedure to do, and she was extremely pleased. She said, please email me the picture while I tried to send it, and it came back. But here's an example of some of the restorative instruments, some of the surgical instruments, syringes, forceps. There's just a lot of junk that we use. And here's a tray set up for an oral surgery procedure, needle holder, scissor, perihospital elevator, etc. So let's just look a little bit at, I'm sure you had all this in school. We had gross anatomy. Half of the semester was general gross anatomy. We had to learn the foot, the arm, and everything else. And then the other half was implant. So this is a little more complicated design here of the. What I want to help you with is we're going to be injecting in this area up here. We're going to be injecting this foramen. This says mandible, but there's a foramen right here where the mental nerve comes out, and it's an important place to know. You can see there the third molars here. I don't recommend attacking those right away. That's kind of all I do nowadays, but of course the nerve supply, the muscles. The interesting thing still to me is that the muscles that, the facial muscles are innervated by the seventh cranial nerve, the facial nerve. The sensation, however, is the fifth cranial nerve. And you make somebody numb, they can still smile. Most of them can still smile. So here we have the trigeminal ganglion, and the mandibular nerve comes down here. We call it the inferior alveolar nerve. And really the only way to get these teeth numb is to inject back here before it goes into the mandible. The mandible has a very hard cortical plate, and it's difficult for the anesthetic to penetrate through. Not so up here in the maxilla. It's a lot more porous, and you can get anesthetic infiltrated in. The thing that's important here is that if you're able to put a drop of anesthetic close to the second bicusspid down here, down in the vestibule, I'm talking just a few drops, you'll have the whole lip and chin right to the midline numb. And I think that's a very useful thing for you to be able to do. Here's the frame coming out. You see it's almost in between the first and second bicuspid here. Here's the cuspid and incisors. And molars. I'm sure you learned all that. Another thing I want to point out is we have a coronating process. This is the condyle, of course, and when it opens, this slides forward. It's a rotational and a transitional joint. And as you come down the mandible, there's a portion that's further back. It's called the coronoid notch. And if you're going to make the mandible numb with the infraalveolar nerve, you go in about the same level as that notch, right about here. I'll have some photos of that a little bit later. And you can make the whole half of the mouth on the mandible numb. You can see back here that at the level of this notch is where that goes in at the lingula. And once it goes into the mandible, you can't do much with it. So if you can deposit some anesthetic prior to entering back there, you can block the whole nerve, and that would include this mental. The whole thing gets numb, of course, with the block. Implant, of course, enters the nerve coming in and comes out this mental brain. You can see on an X-ray the mental brain there. You can actually see the mandibular canal here, and that's where you have to respond. They actually were helping us by certain research. And I'm sure you studied tooth anatomy, enamel, dentin, and pulp. The idea when you do an extraction, this is connected to the bone by a fiber, the periodontal ligament. And if you can break those fibers by luxating the tooth, you can get the tooth to fall out into your hand. That's putting it simply. As you move the tooth with a forceps or with an elevator, you can hear the fibers break. And that's the idea behind it. One of the instruments they came up with is a forceps that actually leans against the buccal bone here and grabs the lingual side of the tooth, and supposedly you can just rotate that out. Now, I have never used these forceps, but for people, they were training some nurses in Ethiopia to take out teeth, and they decided these would be the simplest to show them, and they're working very fine there. The problem is that a set of these costs about $3,000. So if you're going to go out there and do these extractions, you're going to have to put a little investment into it. So what we do is we have our dental syringe. This is sterilizable, reusable, of course, and we have cartridges. I normally either use Septicane 4% with 1 to 100,000 epinephrine, or lidocaine 2%, also 1 to 100,000. There really is no indication ever, in my opinion, and the lectures that I listen to use an anesthetic without epinephrine in the mouth. If you're on a toe or a finger, maybe that's even, they're not sure about that even. They used to think you lose a finger if you inject it with epinephrine. They say that's not true. I don't know. I deal with mouths. There's triple circulation in the head and neck region, and this stuff clears up fast. And there's such a little bit of epinephrine that even a heart patient is not going to have a problem if you avoid injecting in a vein. If you inject in a vein, you're going to get concentration going back to the heart, and we always aspirate when we give anesthetic. Have 30 gauge needles and 27 gauge needles we use. There's a 25 gauge needle, but I don't think you're going to be using any of this. I think you're probably going to be using a plastic 3 cc or 2 cc syringe where you drop some lidocaine or any anesthetic that you prefer, and deposit it where we'll show you here in a minute. So if you want to get a tooth numb, you would put it right buccal to that in the soft vestibule here. You would inject that and get as close to the periosteum as you can. You'll get that tooth numb. If you're just going to do, if we're doing restorative on it, that will make the pulp numb. If you're going to do an extraction, you have to get the palatal side numb also, or you're going to get that other half of the periodontal ligament. As far as the molars back here, here, we use a 45-degree behind the first molar to get the posterior superior alveolar nerve numb. You probably won't use this much unless you're going to be doing something on one of these molars. But just so you know, it's about a 45-degree in and a 45-degree up. And it's real hard to miss. And, just, again, aspirate. If you're giving anesthetic, aspirate. That's what makes these dental syringes so nice. They have a ring, and you just pull back on it and see if you're not aspirating blood, you can go ahead and inject slowly. Yes?
On the last one, you said you had to do the other side so that they didn't help, so you have to do it on the inside too?
I'll show you the palate hole. If you're going to be doing an extraction, you need to get both sides numb. If you're doing restorative procedures where you're putting a filling in, cleaning out decay, then just the buccal is okay. Here's the palate hole. There's where the vertical and the horizontal meet, there's a canal in there that carries the arteries and the nerves. And if you can deposit some here or at the incisal, you're going to cover this whole palatal portion. This greater palatine stops about midway on the cuspid. So if you're working on if you're going to take the cuspid out, you can either inject palatal to that tooth, or you can go ahead and block the nerve right here and by just back of the over here. And then you have the whole palate numb. Looks like it's dirty just a little bit there. Not a problem. The most difficult for dental students to learn, probably for anybody to learn, is the inferior alveolar. And again, the notch here is a good indicator because if you go in on that choroid notch, they're showing it back here. This is the choroid notch right here. And deposit, you're gonna get the nerve numb, blocked before it goes into the bone. And again, that may not be something you use very often. You will automatically, when you go in for this injection, you'll automatically get the lingual nerve because the anesthetic will spread around. I usually use Septicane here because Septicane has a large molecule that one side looks like acid ester, and the other side looks like amide. So it takes effect quickly, but it also stays like an amide. So I use that on the molars. Again, that's a controversy. They're saying paresthesias. Well, there's the literature says there's just as many paresthesias from lidocaine as from Septicane, articaine. So I don't know. I use it and I haven't had any problem. Now there's a pterygomandibular raphe. You can actually see it when you look in the mouth, and you're going to go just lateral to that. And if you bump into bone, so you're starting over here on the opposite bicuspids. If you bump into bone, you just straighten out a little bit, pull back and straighten out a little bit until you lose resistance, and then you're going to get the nerve. Takes a little practice. You may want to contact your whatever dentist you see and ask him to come in and practice a little bit on some patients. Better view. This is coming out over the opposite bicuspids, so it's about a 45-degree angle too. And half the time I bump into bone before I get to the proper depth, and so I just straighten out a little more and slide right in. And here's a picture without the tissue. He's a little low here. I would be up at this angle, but different strokes for different folks. There's stuff on the internet. I happen to bump into this just putting Google images, and this, it's actually a video. But, again, I don't know how involved you want to get in dental procedures. And, so here's in our office in Vista, north of here. This is Rosa. She agreed to be a patient. And, so we're going to just show you in the mouth. This is attached gingiva here, and this is mucosa here. If you just outside the attached gingiva, if you go and deposit some up here, if you're working in the midline area, put it closer in here. If you're working out here, you know, you put it anywhere along there, and you're going to make this whole lip numb. If you have to suture something up, this is ideal. You don't have to be poking around. The kid's screaming, you're trying to poke in the wound, and it's killing. On the lower, same thing. Attach gingiva and the mucosa, and his thumb is hiding it, but just injecting into that soft tissue right there. And if you get a little further back, you'll block the mental nerve where it comes out by the bicuspid, and this whole half over the midline to the corner, to the commissure, to the corner of the mouth. All that will be numb. And if you want to put some anesthetic right in the area, it's already numb. You may want the epinephrine to give you some hemostasis, so it's not bleeding so much when you suture. I think this is a kind way to suture. This is what I want done if somebody's working on it. And my rule of thumb is always, if this were a family member of mine, what would I want to do? And that makes ethical decisions really easy. I don't recommend third molars. We do these, we section here, take this segment out, and then this can come out. These are the easiest ones to do. This is probably more difficult than this one because it tries to go back as it comes out. You have to lift it a little bit with an elevator. It tries to go back, so you end up having to take a lot of bone off or section part of the crown here.
Excuse me,
And then come out. Yes,
when you say I don't recommend third molars, what's that?
taking them out.
Taking them out.
You guys taking them out.
Okay.
Referring to me. No, if you're
No, I
out.
just didn't understand the statement.
Okay.
Like, we shouldn't have them? or-
No.
Okay,
No,
so.
I don't recommend you working on them
Gotcha.
just because you can get yourself in a, you've got structures down here. If you cut too deep here, if you don't have something to cut with, surgical birth,
Okay.
etc. I'm just showing you some of the stuff that we end up faced with.
Gotcha.
And I'll give you recommendations on, I think if you have an infected, swollen wisdom tooth, antibiotics and analgesics are the way to go. Here again. These, you have to take bone off, you have to lay a flat, take bone off, and frequently section part of the crown. These, upstairs, it's, bone is very different, it's softer and easier to use. Easier to get the, this is Independence Pass in Colorado, and I don't know if anybody's driven over to Aspen in the back road, but we were driving back, my sister and I were driving back, and I said, I need a picture of that, so we stopped. I wanted to leave time, we have a video that I'll show you before you leave, but I wanted to leave time for questions, if anybody has anything you'd like to ask. If you could write this down, I don't have a slide on it. The antibiotic of choice for a dental infection is not amoxicillin. And most of my colleagues, amoxicillin. Amoxicillin is a broad spectrum for preventing bacterial cardio endocarditis. What do you call it?
Endocarditis.
What's the name again?
Endocarditis.
Endocarditis, thank you. Tongue tied here. So we don't use amoxicillin. People are abusing amoxicillin in dental infections, and pretty soon they're going to have to find another preventive antibiotic, just like they had to before. The drug of choice, the antibiotic of choice for dental infections, according to Harold Crossley, who wrote the Dental Drug Handbook, is penicillin V, 500 milligrams. And I would give at least number 30, but you could give number 40, and that'll take you for 10 days. 1 QID. Morning, noon, evening, bedtime, is what I tell them. You can put every 6 hours if you want, but people usually get up at night and take it. And yes,
First kind of allergic conditions, do you use Glenda or?
yes, clindamycin 300 milligrams. Number 20, 1 BID. Does that sound reasonable? So, we don't recommend amoxicillin, although 80% of the dentists practicing today are probably right.
If you give that as a little bit deeper, how long do they go, like, say they're not gonna go to the gym?
Well,
That's like a little bit more?
it will get rid of the infection till the resistance goes down again. It'll help them get over the acute infection they have. I usually tell people heat, combine it with heat, hot packs on the outside, hot rinses on the inside, and the heat's gonna open up the circulation and help clear that up too. There again, if you have the equipment and you can take the tooth out, get them numb and take it out. I only delay an extraction where there's infection if I can't get them numb. Sometimes the pH around that infection is kind of acid, and you need a slightly alkaline tissue fluid to change the salt, the HCl anesthetic salt, into free base, so it can be absorbed by the nerve. And if the infection makes it too acid, you just say, I'm not getting numb, can't do it. I had an oral surgeon tell me one time I had trouble with a tooth my first year out of school. I was in Puerto Rico. And I called him, I said, I can't get this tooth out, it's up here in front. And he came by, and he said, you need help? I said, no, I came out. He says, yeah, I thought maybe you couldn't get it numb. He says, the only reason I know of you can't get a tooth out is you can't get it numb. Anything else you can get out. And anytime I'm having trouble, to this day, I graduated 40 years ago, to this day, if I'm having trouble, I tell myself what he told me. You can get anything out, it's numb. So, yes?
If you mix the lidocaine with like bicarb, does that help at all?
Maybe inject the bicarb first, and then put the anesthetic in. I don't know. It's a good thought, though. That'd be a good research project. Anybody else? Yes?
When you're numbing the tooth up to extract it, how much saliva do you put in?
The cartridge you probably saw was 1.7. They used to be 1.8, but you know the economy. 1.7. On the lower, I would probably use most of that for an inferior alveolar. For the infiltration, maybe a third. Again, if I'm only making the soft tissue numb, I would put a few drops. My teachers told me you use the minimal amount that will get the job done. And I don't know if you remember Tony Protopappas in Orange County had a couple of patients die, and they thought it was the deep sedation he was using. One of the patients that died, he had put in 52 cartridges. Well, 52, if you can believe that. On an adult, an average 150-pound adult, the limit is, if there's no anesthetic, is 9 cartridges. If there is anesthetic, it's 13, because it's not going to reabsorb this.
You mean epinephrine?
Pardon?
You mean if there's epinephrine?
If there's epinephrine, vasoconstrictor. So 52, they died of a lidocaine overdose. Yes?
When you're doing like an inferior alveolar block, what are the, aside from not aspirating and hitting a vessel or something, is there a chance of damaging a nerve? Because I work in the ER and they're so scared to let the mid-levels.
Oh, I know.
I don't understand why.
I don't understand it.
Okay.
You can charge in there and help them. The only way I can see of getting a paresthesia, and it'll usually heal, maybe take 2 or 3 months, but You'll feel a little funny, but after 2 or 3 months, it should be normal, is if you actually poke the infraalveolar nerve. And what people will feel is electric current out to their chin. And if they jump, when I'm giving an anesthetic, I usually ask them afterwards, what did you feel? Did you feel electric here or on your tongue? And most of the time it's tongue, but occasionally it's here. And the aluminum touched the nerve and caused
And so they might have a prolonged paresthesia.
paresthesia is partly numb, tingly or something like that. They might. It's very rare.
That's the worst case scenario.
Worst case. If you inject in an artery, you will vasoconstrict the peripheral from that, and you'll see white tissue, which will go away in a minute or two. The epinephrine has a very short half-life. If you inject in a vein, it goes centrally, of course, and you could get some palpitations. Some people will say, I'm allergic to epinephrine. And I'm thinking, how can they be allergic to something that their adrenal gland secretes when they get that? And that's why I use epinephrine in everything, because if I can get a better local anesthetic and they're going to feel no pain, they're not going to excrete or secrete endogenous adrenaline. Yes?
Some people with tooth impaction, sometimes Norco, sometimes even Percocet doesn't stop the pain. Would you suggest like a block, like a Marcaine block?
Exactly. Even if you cannot get right on, if you can get some anesthetic back there and they can get some relief. By the way, my friend from Ethiopia, and that's where the video will be from, my friend from Ethiopia says the biggest cause of suicide on the continent of Africa is toothache. And I never thought about it, but a toothache day and night would make you want to end it all. I mean, it's there. One of these clinics, the closest dentist is 600 miles away, so there's no hope. Yes?
When you do a Marcaine block, how long do they get relief for? Like how sustainable is that? Maybe like a few hours or?
We're back to the bell curve. Some people would be numb 8 hours, some people 4. And if it has epinephrine in it, which we would prefer, it'll stay there longer.
Approaching other dental related infections like getting rid of PTA if you're out in the field somewhere, what do you recommend?
A PTA.
Yeah, peritonsillar abscess.
Oh. I don't work on tonsils, but I would give anesthetic I&D.
Careful.
Well, give me some help here.
If I was going to IND, I'd be very careful. Clinda and probably prednisone, but the only cure for that is if it's an abscess, it's a blade.
Is what?
IND, for sure, no matter where you are. They have to go somewhere to get it cut off.
Yes.
Is there a preference of lidocaine versus septicane in a hypertensive patient? And if you're on the field and you have someone who's severely hypertensive, what is the level where you would continue to do dental work on them versus?
Good question. I would probably send someone out of the office to their cardiologist or their internist or their TA. If they were over 160, 150, 160, top number. They treat up to 200 systolic. Diastolic is probably more important, and if that's over 100, I wouldn't work on. I wouldn't inject epinephrine.
And how long, let's say that you've got someone with a pretty severe dental abscess, would it be reasonable to get on antibiotics for 10
Yes.
days, try to control their BP and then have them come back?
Your safety net is always antibiotic. And if you think they need it, some pain med. Yeah. Good question. Yes.
I have patients coming to me for dental clearance that are on Coumadin, or like AFib.
And the dentists I talked to say as long as the IH is less than like 3, they just usually leave them on it and send them to the dentist. What's your recommendation? Or would you stop it for 2 days?
I don't, you guys could, I don't stop anybody's Coumadin. I had a patient who was on Plavix, aspirin. I don't think he was taking Coumadin.
There's just like a tooth extraction, so anything like
Yeah.
hardcore.
Well, I called the cardiologist and I said, do you want to adjust anything? Or he says, no. He says, go ahead. Just tell him it's going to bleed a little longer, but keep pressure on it. And that's another thing, by the way. A lot of dental patients, when they bleed, will go to the ER. The ER doesn't know what to do, and they give them vitamin K. Won't help unless, of course, they're deficient in vitamin K. The best thing, the only thing I know of to treat a bleeding extraction site is pressure. And a lot of people will, third molar, they'll bite on the second molar with the gauze. There's no pressure on the third molar area. Just put it behind, you have to put it right on the surgical site and you have the pressure there. And 10 minutes of pressure, if you can get them to bite down for 10 minutes, have them just wait there. Take out the gauze and verify hemostasis and let them go. And charge them.
And since we're in the global health, can you talk to us about some local remedies? I know green teas, some people use, but there's also maybe herbal we can use, the local one?
I don't know of any. I do know that when pressure has not stopped a bleeding site, that a tea bag will vasoconstrict. I'm not even sure that it has to be green or black or, but theophylline in the tea will help it. But other than that, I do not know any alternative. How are we doing? This, I really love this video. This is in Ethiopia. You see another primitive site. And this is how caring for people who really need it affects these dental students. There's a high-headed student there too, and one of the students gets overwhelmed a little bit with this whole idea of helping people. If you can get the fire lit in dental students when they're studying about helping the global situation, they'll be hooked for life like I was.